Welcome, everyone. Welcome to our third Newborn Toolkit webinar with our partners at PATH and counting. Welcome. We're delighted to be marking World Breastfeeding Week this week with this webinar, and happy World Breastfeeding Week. Today's webinar is on most fragile babies, fragile contexts. How do we support breast milk feeding? Welcome. Please introduce yourself in the chat. If you have a new, please introduce yourself in the chat. So you see on your screen an interpretation globe where you can translate this webinar from English to French. Welcome once more to our Newborn Toolkit PATH webinar to mark World Breastfeeding Week. Next slide, please. Welcome once more. Just a reminder on what the Newborn Toolkit is and who we are. The Newborn Toolkit is a multi-country, multilingual learning community for high-quality small and sick newborn care. We're a growing community with over 62,500 visitors from 200 countries and territories in 2025. And we aim to be a one-stop shop, bringing together more than 1,000 tools in 15 languages, technical content in French, and linked communities of practice in English and French. And this is all to meet the national targets for SDG 3.2 for newborn survival that cannot be met without small and sick newborn care. Next slide, please. Welcome once more to the Newborn Toolkit webinar with our partners at PATH. Most fragile babies, fragile contexts, how do we support breast milk feeding? Join the Newborn Toolkit community to hear about webinars, news, and share tools and ideas. You can sign up to our Toolkit newsletter on the screen now in English and French, and follow us on Blue Sky, Twitter, LinkedIn, and Facebook. Next slide. So just a bit about our past webinar recordings that are all available on our website. In 2024, we had a webinar on why does breast milk matter even more for vulnerable babies, also with the PATH team. And last year in 2025, we had a webinar on lactation, breastfeeding support for small sick newborns and their mothers, creating sustainable systems change. And on the screen, you also see a QR code where we can continue our learning with the nutritional support resources on the family-centered care health system building block component of the Newborn Toolkit. So you're welcome to grab your phones and go use that QR code and explore what other resources are available on the Newborn Toolkit. Next slide, please. And upcoming webinars. We have a webinar on 8th September to mark World Sepsis Day, and we already have quite the dynamic title, Neonatal Antimicrobial Stewardship, Today's Use, Tomorrow's Antibiotics. And we welcome you all to join in and share that webinar as well to continue learning together. And then on the 20th October, we have our perinatal palliative care webinar, which we'll be sharing with you all in due time. Many more exciting webinars to come, and we'd like to thank you for joining this webinar. My name's Dr. Paolo. I'm a clinical researcher and one of the knowledge management co-leads of the Newborn Toolkit. Once again, this webinar is being translated to French, and we are glad to welcome you all to this very dynamic Newborn Toolkit PATH webinar. Next slide, please. I'll now hand over to Lauren. Lauren, over to you.
Merci. Donc, bonjour et bienvenue à tous nos participants parlant français. Si vous voulez écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton de traduction affiché sur le barre de menu de Zoom pour accéder à la canal français. Je veux aussi noter quelques webinaires à venir. Le 8 septembre, un webinaire qui se concentre sur la gestion des antimicrobiennes en néonatologie, l'utilisation d'aujourd'hui, les antibiotiques de demain. Et le 20 octobre, un webinaire sur les soins palliatifs périnataux. Donc, nous vous invitons à nous rejoindre pour les prochains événements. Next slide. And I'm excited to introduce our host, Dr. Emily Njuguna. So Dr. Emily is the Africa lead for maternal and newborn health with PATH. and she has a background as a pediatrician, and we're very excited to have her back today. She was our host last year as well, so welcome back. And without further ado, I will hand over to Dr. Njuguna. Thank you.
Thank you. Thank you so much. Good afternoon, good morning, good evening, wherever you're joining us from. We're really excited to welcome you to this webinar celebrating World Breastfeeding Week. And this year's theme is really looking at breastfeeding for a sustainable start in life, strengthening what works. And this year's theme focuses on tracking progress, evaluating impact, and scaling proven approaches that improve breastfeeding outcomes. As you've heard, I'm Dr. Ameena Goga, a pediatrician based in Nairobi, Kenya, and I am the Africa lead for maternal and newborn health at PATH. It's a great pleasure for me to be your host today. Welcome all. Next slide. Before we begin today's webinar, I would like to share some exciting news coming from our colleagues at WHO and UNICEF. They will be releasing 2 key documents in the coming weeks that relate to human milk banking and the use of donor human milk. This is the culmination of many years of effort and advocacy around the need for global guidance in this area. The 2 resources are, one, the WHO Standards on Human Milk Banking, which really focuses on evidence-based recommendations for safety and quality of donor human milk. And the second will be implementation guidance on donor human milk banking. This is really, really exciting news coming from our colleagues. We are expecting to hear very soon about the exact dates for the dissemination, so be on the lookout for that dissemination coming up. Next slide. So to start us off, and by way of introduction, we know that many babies around the world, particularly those in fragile contexts, do not have access to breast milk. When a context turns fragile, lactation support and breast milk feeding is usually the first thing that falls through the cracks. And this means that any small and vulnerable baby is then left at the whims of what's happening wherever they are. They are left vulnerable and they tend to have adverse morbidity and mortality outcomes. So over the next hour, we will hear from 4 exceptional colleagues who will walk us through the evidence, but also they will share their experiences working in fragile contexts or zones. Starting us off, we will hear from Dr. Ameena Goga. Ameena Goga is a pediatrician and a certified lactation consultant with a master's in mother and child health and epidemiology, and she also holds a PhD as well. She works as a scientist and a medical officer at WHO, and she previously worked on infant feeding and HIV in South Africa, including 5 years at the Ministry of Health. In her talk, she will be sharing with us what the evidence tells us about breast milk feeding and what we can do to support those babies and those families who are in fragile contexts. So Dr. Ameena, over to you.
Thank you very much, everyone. It's wonderful to be here, and thank you for the kind introduction. Next slide, please. So in my talk today, I will be focusing on, I don't know if the slides are advancing, but I didn't see them advancing. So maybe just double check. But in my talk today, I will just be looking quickly at what is the definition of a vulnerable infant, what is the scope of the talk, what are the standards for breast milk feeding support, and then how do we provide breast milk feeding support for vulnerable infants in fragile contexts? If you can go to the next slide. So what is a vulnerable infant and what is a fragile context? Vulnerable infants are can either be term appropriate for gestational age, term small for gestational age, preterm, either appropriate or small for gestational age, and then we can have the small or sick newborn. And depending on where you are, a vulnerable infant can be all of these. So if we're in a conflict or war emergency situation, even a term appropriate for gestational age infant is vulnerable. If one is in a stable, well-resourced setting, then usually we say the preterm small for gestational age, perhaps this preterm AGA, the appropriate for gestational age, and the small and sick newborn are vulnerable. But in the context of what we're discussing today, I'm going to focus on the last 2 columns. So babies who are born in epidemic or pandemic situations, and particularly babies born in conflict, wars, or emergencies. If you can go to the next slide. So I'm going to talk about the standards for breast milk feeding. I'm not going to go too much through the evidence there's been of why we're supporting breast milk feeding. I think there's so much written about that, including 2 or more Lancet series. So I'm going to now focus on operations. How do we put these into practice? What are the standards for breast milk feeding support in all settings, with a particular focus on these conflict and war settings? So if you go to the next slide, I'm going to reference this implementation guidance that was released from WHO around 2021. The document, after lots of consultation, suggests that each woman, each mother, each baby pair should have 6 breastfeeding counseling contacts. They should occur at stipulated periods. Firstly, there should be at least 1 in the antenatal period. Secondly, immediately after birth in the postnatal period, between the first 2 and 5 days, or 2 to 3 days of delivery. Third one at 1 to 2 weeks after delivery. The fourth one at around 3 to 4 months. This is really the time when infants have a growth spurt. The fifth one at 6 months of age. And the sixth one after 6 months of age, when complementary feeding has started. And then there might be additional contacts as necessary. And if we look at our distribution of babies, we have the term AGA, term SGA, preterm AGA, and preterm SGA. All of them as a baseline, as per the recommendation, need 6 breastfeeding counseling contacts. But the preterm AGA, the preterm SGA, the small and sick newborn, usually need additional visits. And in conflict or emergency settings, it is likely that the term SGA will also need additional breastfeeding counseling visits. So how do we make that possible, and what does it entail? If you go to the next slide, the implementation guidance suggests that the package of basic counseling skills should include listening and learning. If you can go to the next slide, thank you. Should include listening and learning. So really listening to the mother, building her confidence, giving support to the family, assessing and documenting what exactly is going on with the feeding history in this baby. How does breastfeeding look? What does the observation look like? How is attachment? How is positioning? And then to provide assistance to mothers, to initiate breastfeeding within the hour of delivery, to position themselves so that it's comfortable for them to breastfeed, to hand express or express using a pump if it is available, to manage breastfeeding difficulties. And if this is happening during the antenatal period, then to prepare the pregnant women for breastfeeding. And then, of course, referral. Referral is an essential part. And if you go to the next slide, the trouble is that in these, if you go to the next slide, thank you. And the trouble is, no, that was fine. The trouble is that in these vulnerable settings, advanced breastfeeding counseling also includes assisting mothers with mastitis. And how do we do that in these vulnerable settings? If we go to the next slide. The document suggests to apply a 3-step counseling process, and that really is to assess the situation, to listen and learn, to ask questions, to observe a breastfeed, to then analyze the situation, prioritize the issues that need to be addressed, and then to act. And acting means not just doing, but doing what is supportive to the mother-baby pair. If we go to the next slide, the question really is that in conflict settings, when we have breakdown of many systems, how do we make this happen? So if you go to the next slide, and the next slide. Thank you. So how do we make this happen, particularly in emergencies? But then out of emergencies, how do we anticipate so that we are prepared when this occurs? So in emergencies, this is a difficult one. But what often needs to happen is governments, other groups, humanitarian aid agencies must prioritize the protection, promotion, and support of breastfeeding. Identify which human resources can deliver not just facility-based breastfeeding support, but community-based support as well. What resources exist? Can they function? And in the context of the emergency, what can they do? So how could their skills and time be best used? So it requires a lot of planning. It needs somebody, a champion, to take control, or not take control, but take charge of the situation, to make some decisions about how to use, or firstly to assess what's available, and then to make some decisions about how to use what's available. And then if we're not in an emergency yet, the important thing is to anticipate emergencies and conflicts, to plan ahead, put people, especially mothers and babies, in the center, to make sure that breastfeeding counseling is an integral part of any emergency preparedness and response plan, and to build resilience in the system. So if you go to the next slide, we've heard about the 6 building blocks of health systems. They all need to be worked on. If you can click again, the trouble is that in conflict or emergency settings, we don't know how service delivery is taking place. The health workforce might be unstable. Health information systems might not exist. For breastfeeding, you don't necessarily need access to essential medicines, so perhaps that does not matter, but there's probably hardly any financing and hardly any leadership or governance, which really then compromises the resilience of the system and compromises what we can do. The most important thing, and if you can go to the next slide, is in working through an emergency or planning for an emergency, is to put the mother and the baby in the center of what we do. It's not about other things. It's about this vulnerable newborn, the mother, and the support system that the mother has around her. If you can go to the next slide. So what do we do? Essentially, we need to plan ahead, not just wait for the emergency to arise. And there's 7 steps or actions that need to take place. 1 is to make sure there are relevant policies in place. Policies that will guide or govern governance and government and humanitarian agencies that protect the promotion and support of breastfeeding, to prohibit the donation of breast milk substitutes. And we will be hearing more about that today, because very often companies capitalize on emergency and conflict situations, but pre-crisis policies could prevent this. Secondly, to ensure that human resources are available, so to invest in staff, prepare staff to support and protect and provide breastfeeding counseling. Thirdly, to develop capacity to provide breastfeeding counseling. If you can go on to the next slide. Fourthly, to establish monitoring and evaluation systems. Might be difficult, but we need to think about them ahead of time. Ensure tracking and monitoring of counseling, but also tracking and monitoring of breast milk substitutes, just to make sure that nobody's taking advantage of the situation. Action 5, to make sure that there are adequate financial resources allocated, to make sure that breastfeeding counseling and emergency is integrated into emergency response plans, and to put health, nutrition, and social service coordination mechanisms in place with mother and baby at the center. So in summary, if you go to the next slide, feeding vulnerable infants breast milk in fragile settings or fragile contexts must be protected. It really is best done if there are appropriate terms of reference and policies for humanitarian aid and pre-planning. Human resources to provide support are critical, and we need to make sure we invest in them ahead of time. And lastly, community support underpins success, especially when all systems break down. We need to think through what is the community, who is the community available to provide support. Thank you so much. Happy to take any questions in the chat, or you can email me. Thank you so much.
Thank you so much, Dr. Ameena Goga from WHO. That was a wonderful presentation. And she shared with us some of the evidence that we have around ensuring that we are feeding babies even while they are in fragile contexts. Next, we're going to hear from Dr. Mariana Popoca from MSF. Dr. Mariana is a pediatrician with an MSc in tropical pediatrics and the pediatric advisor for MSF. Since joining MSF in 2018, she has worked across diverse humanitarian settings and is based at the MSF headquarters in Paris since 2024, where she leads initiatives in breastfeeding, newborn care, and infant malnutrition. She will be speaking to us about her experience on the front lines, supporting vulnerable newborns with breast milk feeding in crisis settings. Dr. Mariana, the floor is yours.
Thank you so much, Emily, and thank you for that presentation. I will be speaking today about a strategy that, precisely as Dr. Ameena Goga was saying, puts the mom and the baby at the center of the interventions. And we're going to be talking about separation as a model of care that ensures breastfeeding in vulnerable newborns. Next, please. So I'm just going to start by declaring that I have no conflict of interests. Next one. And I'm pretty sure many of you are familiar with this graph where we see that in the last 30 years, global numbers of mortality in pediatrics under the age of 5 years old has decreased dramatically. It has been a huge success. It has decreased around 60%. However, neonatal mortality has not decreased that much, and it actually represents almost half of the deaths of children under 5. And the leading causes of mortality are prematurity, birth complications like birth asphyxia and birth trauma, neonatal infections, and congenital anomalies. And these are the same patterns that we see in MSF. Next, please. I just wanted to give you a little bit of an overview of the numbers in MSF. So for 2025, in all of the maternities that MSF is supporting, we had over 400,000 deliveries. This includes vaginal and C-section, from which around 22% of these babies needed further care in one of our neonatal units. That is more than 92,000 newborn babies in 2025. And these newborn babies, given the contexts where they are born, they would all be considered fragile or vulnerable. This also, it's important to see how this only represents 11% of all pediatric admissions under 5 years of age in the MSF sphere. And I included these graphs under to show that we mainly have projects covering Africa and Asia, where we have most of our newborns admitted, and our leading countries with the most amount of neonatal admissions per year are Afghanistan, Yemen, Sudan, but the list goes on. Next, please. So I want to mention the case for quality here because it used to be in the past that most of preventable deaths of treatable conditions would happen because of the lack of access to care. But now 60% of people that die in worldwide due to treatable conditions die because of a poor quality of care rather than because of the lack of access to care. And this is, I'm mentioning this because separation is such a great example of an intervention that is easy, that improves quality of care, that puts the mom and the baby at the center of the equation, that improves breastfeeding overall, but also neonatal mortality and many other things, and does not require a huge budget. It just requires reallocation of the resources that are already existing. Next, please. So we all know that the mother has will have milk production and the chances of successful breastfeeding that are linked to whether the mom and the baby stayed together in the first 72 hours of life. Of course, after that, breastfeeding can still happen with support, but the best is to keep mother and baby together. And we also all know about kangaroo mother care and how it is the standard of care for low birth weight and premature newborns. However, the concept of zero separation goes beyond that. Zero separation is recommended for all babies, term, preterm, sick or healthy. Everyone should be receiving zero separation care. And zero separation has a component of physical proximity, meaning keeping mom and baby together. If this baby needs to be admitted into the neonatal ward, we need to keep that baby with her mom. Or if the mom needs treatment, mom and baby should stay together during that treatment as well. But it goes beyond physical proximity. It is a coupled care for both mom and baby at every stage and every level. And I'm going to explain a bit further on that on the next slide. It promotes, obviously, breastfeeding and skin-to-skin contact, but not only that. This is what zero separation could mean at different levels of care. So we have at the top, we have the community care level, then in the middle we have primary care, and at the bottom we have secondary or tertiary level facilities. And as you can see, this is kind of like a roadmap of what could happen within the places where you are working, the projects or the countries where you're working. You can identify where are you in this scale and how can you make happen like zero separation happen in different places. So I'm going to take the example of secondary and tertiary care, for example. So if you can start reducing the physical separation from birth, that is already a big step. Ensure that essential care is offered to both mom and baby whenever you have the opportunity. That is the next step. But if you go towards the area where is the darker pink, then let's say the best would be to have units that are conceived to treat mom and baby together with multidisciplinary teams where we are not separating them. Next, please. It is important to say that even research has declared unethical to continue to separate mom and baby from studies. So I wanted to mention this Cochrane study and this study done on kangaroo mother care. So kangaroo mother care, obviously for low birth weight babies and preterm babies, but the Cochrane study was made also for term babies, full term babies with no issues, and where the researchers say that the evidence in favor of immediate skin to skin for all babies is so overwhelming that it is considered unethical to keep on separating them. Next, please. So this is an example of a blueprint that MSF had been working on for the last couple of years on mom and baby units or zero separation units, where basically the structure is there where we have mom babies next to the baby cots. Everything that is needed to take care of the baby, but also anything that is needed also to take care of the mom. So if the mom had a postpartum hemorrhage and needs a transfusion, the transfusion can happen in this unit. And if the baby needs oxygen support and is receiving antibiotics, the baby stays next to the mom. And we promote skin to skin, we promote breastfeeding, and this obviously has a huge impact in neonatal morbidity and mortality. The next one, please. So I'm just going to finalize with a small example of the impact that this has had, for example, on breastfeeding in the first hour of life. So the zero separation strategy started in MSF in 2023. Obviously, it has not been an implementation of everything of the package everywhere. It goes step by step. But let me just tell you that in 2023, we did not collected any data on breastfeeding in our facilities. So when the zero separation strategy started, projects started wondering if they should make these indicators of their quality, monitoring how many babies were put in the breast in the first hour of life. And so some projects started in 2025 to roll out this zero separation strategy within their maternities, and they started collecting data. And the data it's evident that the moment that this implementation started, the babies put to the breast started increasing. So we see in the beginning of 2025 how that was about 40% of babies in all of these projects that were being put to the breast in the first hour of life. And as we go towards the end of 2025, that number is already 75%. So can you go to the next slide, please? So as key messages to take today is keep mom and baby together, consider them one for the first month of life, and whenever you can, offer coupled care for both of them. Thank you so much.
Thank you so much, Dr. Mariana Popoca from MSF, who's given a wonderful presentation on the need for zero separation, ensuring that we are coupling care across every level of care for mothers and babies. We are going to move on and hear from Dr. Franck Houndjahoue. He is a pediatrician with more than 11 years of experience in newborn and He has expertise in policy building and neonatal quality improvement in humanitarian settings, including Haiti, the Central African Republic, Sudan, and Chad. He also is the executive committee member within the African Neonatal Association, and since 2025 was appointed the technical advisor to the Paolo Chiesi Foundation. From him, we're going to hear about how maternal health shapes breast milk and newborn outcomes in vulnerable settings. Dr. Franck will be making his presentation in French, so please use your interpretation button at the bottom of your screen for English translation. Over to you, Franck.
Thank you, Emily, for introducing me. Comme Dr. Emily vient de dire, ma présentation sera en français. Merci de me permettre de partager avec vous comment la santé de la mère peut impacter la qualité du lait et par conséquent la santé du nouveau-né dans les contextes humanitaires. Diapo, s'il vous plaît. Voilà le plan qui nous permettra de passer le message de cet après-midi sur l'alimentation de la mère et l'impact sur la qualité du lait maternel. Diapo, s'il vous plaît. Diapo. Merci. En réalité, nous savons tous que l'allaitement maternel, c'est l'alimentation par excellence du nourrisson, du nouveau-né, du nourrisson, pour tous les avantages qu'il présente, la croissance harmonieuse, le développement neurologique, et voilà, et tout le bon environnement que cela peut créer à cet enfant dans sa croissance harmonieuse. Et il a été également démontré que si tous les enfants sont allaités au sein pendant les 2 premières années, cela pourra permettre donc de sauver au moins 800 000 enfants de moins de 5 ans. Et la période critique, c'est la période communément appelée les 1000 premiers jours, qui s'étale depuis la conception jusqu'à la fin de la 2e année. Cette fenêtre est une fenêtre qui conditionne même le reste du parcours, je peux dire même la vie de cet enfant dans le futur. Alors, la mère, quand elle n'a pas une bonne alimentation, elle ne pourra pas non seulement rétablir de son parcours de la grossesse et donc être dans des conditions optimales pour alimenter son enfant et favoriser donc ce développement harmonieux dont nous avons précédemment parlé. Diapo, s'il vous plaît. Slide, please. Malheureusement, la malnutrition des femmes enceintes et des femmes allaitantes, on n'en parle pas très bien, on n'en parle pas assez, j'allais dire. Et les statistiques montrent que les prévalences augmentent quand on passe de 2020 à 2022. La prévalence passe de 5 millions d'habitants, 5 millions, pardon, de personnes atteintes, de femmes atteintes. Et en 2022, nous sommes à près de 7 millions. Les facteurs associés à la composition du lait maternel sont légion, mais nous allons particulièrement insister sur l'alimentation de la mère. Alors, il y a un élément extrêmement important qui... Dr. Emily, can you hear me? I read that it's glitching.
Yes, we can hear you, Franck.
Okay, thank you. Donc, je disais que l'allaitement maternel, l'alimentation de la mère va également conditionner, fait partie des facteurs qui conditionnent la composition et je dirais même la qualité du lait maternel. Et comme exemple, nous avons un élément essentiel que nous connaissons très bien, qui sont les acides gras polyinsaturés qui interviennent dans la maturation cérébrale et nous, avec comme avantage la capacité d'apprentissage, la capacité de mémoire, la capacité de réflexion. Et cet élément, qui est un élément essentiel du lait maternel, est conditionné par l'alimentation de la mère. Ça veut dire que lorsque la mère se retrouvera dans des conditions où l'alimentation sera compromise, évidemment, ce sont des éléments qui vont manquer dans son lait et qui vont impacter, ces éléments vont impacter également la qualité du lait et donc la santé de l'enfant. Il en est de même de certaines vitamines, pas toutes, mais de certaines vitamines liposolubles, hydrosolubles sur lesquelles nous allons revenir. Slide, please. Alors, ce graphique pour montrer ce phénomène dont on ne parle pas encore suffisamment dans les contextes humanitaires, vous voyez, 12 pays, sur ces 12 pays, nous avons une dizaine de pays en Afrique et de 2020 en orange circulaire, en 2022, le triangle vert rosé, je peux dire comme ça, on voit qu'il y a une progression, malheureusement, une augmentation donc, de la prévalence de la malnutrition des femmes enceintes et des femmes allaitantes quand on est de 2020 à 2022 dans une dizaine de pays sur une douzaine. Tous ces pays sont des pays qui ont connu différentes sortes de contextes humanitaires. Slide, please. Alors, la composition du lait. Le lait est composé de 87% d'eau, ce qui permet de tancher la soif du nouveau-né et du nourrisson jusqu'à l'âge de 6 mois sans ajout d'eau, 7% de lactose qui est le composant essentiel de glucides, 4% de lipides où nous pourrons distinguer les cholestérols, les triglycérides, les acides gras polyinsaturés, oméga 3, oméga 6, les DHA, ARA, ALA, tout ça. Nous avons 1% de protéines. Et nous avons d'autres éléments qui vont renforcer donc le système immunitaire de l'enfant, j'allais dire. Nous avons des composants, notamment les immunoglobulines A. Nous avons des composants qui vont renforcer le microbiote du nourrisson et lui permettre donc de facilement affronter les infections. Et il est important de savoir que la composition du lait non seulement change au cours de la même tétée, mais change également selon le stade de la lactation, donc change d'un moment à un autre. Les facteurs qui vont impacter la variation de l'allaitement ou du lait maternel seront l'alimentation de la mère, comme nous avions dit, la physiologie donc de la grande mammaire, l'état nutritionnel, le degré de la prématurité et le moment de l'allaitement. Pour illustrer cela, nous pouvons vous dire simplement qu'au début de l'allaitement, au cours d'une même session de tétée, nous avons plus de lactose et de l'eau qu'à la fin de la tétée, nous avons plus de lipides. Diapo, slide please. Alors, que désigne-t-on par contexte vulnérable ou contexte humanitaire? Je ne vais pas trop insister sur ça parce que Dr Goga a parlé de ce qu'on appelle contexte humanitaire. Par contre, quand on est dans ces contextes-là, quels sont les défis auxquels nous sommes confrontés? Nous sommes confrontés justement à un problème de l'état nutritionnel de la mère parce que l'accès à l'alimentation adéquate n'est pas, les conditions ne sont pas réunies. Elle va être confrontée à des infections qui vont également fragiliser son état nutritionnel. Elle va être confrontée à un contexte de stress selon le type de contexte vulnérable, selon que ce soit une catastrophe, un conflit, une sécheresse, ainsi de suite. Et ce sont des situations qui vont malheureusement déstabiliser le système de santé et donc limiter l'accès aux soins. Tout cet environnement donc vont compromettre l'accès et l'alimentation de l'enfant. Slide, please. Alors, quand la mère est dénutrie, est-ce qu'elle peut alimenter son enfant? Comprenons d'abord ce qui se passe. Quand elle est dénutrie, il y a quand même des réserves qui vont au niveau de l'organisme. Les réserves de son organisme vont être récupérées au profit donc de la composition du lait. Le volume ne changera pas, les lactoses, les protéines et certains minéraux ne changeront pas. Mais deux points fondamentaux, je voudrais dire les vitamines B et les acides gras polyinsaturés, ces éléments-là vont malheureusement être compromis et donc vont affecter la qualité du lait. Diapo, please. Slide. Et donc, cette compromission affectera le développement harmonieux de l'enfant. Néanmoins, la mère doit continuer à allaiter son enfant parce que ce lait est quand même d'une qualité suffisante pour couvrir les besoins de son enfant. Mais la situation qui devient plus dangereuse, c'est lorsque l'état nutritionnel est sévère. Diapo, s'il vous plaît. Slide, please. Alors, comment soutenir les mères dans des contextes comme ça? Il faut donner la priorité à ces mères, il faut leur permettre l'accès aux services, notamment les services de conseil et de soutien de l'allaitement maternel. Il faut faire une supplémentation en micronutriments précisément le fer, l'acide folique. Il faut apporter un repas supplémentaire à ces mères, sachant qu'en période d'allaitement, elle a besoin encore de 500 calories, contrairement à une femme qui n'allaite pas. Slide, please. Alors, il faut également tenir compte du contexte qui impacte, qui impacte son état psychologique. Et donc, il faut faire recours à des psychologues et aussi utiliser, selon le contexte, les pères, ces autres femmes qui allaitent et qui ont fait la preuve, qui ont montré l'avantage de cet allaitement. Et également, dans la communauté, il faut faire recours aux ressources de la communauté. Il faut aller au secours de cette mère en allégeant ses charges. Et donc, il faut faire preuve donc, de la solidarité africaine. Et c'est là qu'il faut préparer l'accouchement. Il faut savoir qui va assister cette mère quand elle aura son enfant pour également la soulager dans les tâches quotidiennes par rapport aux autres enfants et par rapport à la charge de la famille. Slide, please. Alors, quelques questions quand même restent non résolues. Et les critères d'admission ou de sortie d'une femme enceinte ou d'une femme allaitante dans un programme nutritionnel et également des recommandations comment gérer l'état de dénutrie d'une femme allaitante ou d'une femme enceinte. Slide, please. Slide, please. En conclusion, nous allons dire que l'allaitement maternel demeure un aliment sûr, nutritif et fiable pour les nourrissons de moins de 6 mois, particulièrement dans les contextes vulnérables. La nutrition maternelle est essentielle si nous voulons également garantir une bonne santé pour l'enfant parce que ça conditionne la qualité du lait. Soutenir les mères à travers donc l'accès aux soins, à travers également des soins psychologiques, à travers également les décharger de tout ce poids de la société et retenir essentiellement à la fin de ma présentation que le bien-être de l'enfant passe par le bien-être de sa mère. Je vous remercie. Thank you.
Thank you so much, Dr. Franck, for sharing your insights on the work that you have been doing. We definitely do appreciate your insights and looking forward to hearing from you as you continue this work. Next, we're going to hear from Alessandro Iellamo, who is a Senior Emergency Nutrition Advisor for Crisis Response and Resilience at FHI 360. He's going to be sharing his experience supporting breast milk feeding in conflict regions around the world. Alessandro, over to you.
Thanks, Emily, and thanks, everybody. So I'm going to give you a brief overview of not how to protect breastfeeding alone, but also how to understand what are the threats and the risks around breastfeeding during a crisis and during a conflict, as it has been shared earlier. So next. First, again, I think it's always very important to look at the context where we are. And this is a picture of today, more or less. I think every day we are listening, we are hearing things that we don't always like about conflict, about new conflict, about re-emerging conflict, and chronic conflict, chronic emergency, and so on and so forth. So what is the picture today? It's estimated that basically we are having around 239 million people around the world in need of humanitarian assistance. It's estimated that as of mid last year, so this number may be actually larger, we have around more than 100 million people forcibly displaced. And recently, we just had 2 famines declarations, one for Gaza and one in Sudan, in certain locations. So what does this all mean in terms of the context where we operate or we support governments to operate? We have more needs, as you all know, less funding to operate, and certainly greater risks for the infants and for the mother. Now, what all of these emergency do, or all of these crises do in relation to infant feeding? Well, basically it weakens our support systems, our health systems, our supply chains, our water and sanitation systems, our fuel, and so on and so forth. So all of these components, when are extremely affected by crisis, will have a direct impact on the infant feeding situation in the context. And let's add additional pressures that converge to create more, to disrupt even more infant feeding in a crisis context. The conflict and insecurity, the climate and food system shocks, forced migration, as I said, and separation, and the chronic health system instabilities. So all of these are ingredients for severe concerns, severe challenges, disruption of optimal or recommended infant feeding practices. Next. So what has been the experience? And that's why I wanted us to look at a bit of a consolidation of our 20 years or more of experience in humanitarian context. The experience, again, unfortunately, is not good news. No? The experience is when we look at infant and child feeding in the emergency sector, it's generally underfunded, deprioritized. It's never clearly, there is never a clear allocation to protect and promote breastfeeding or complementary feeding for that case. We are always working in contexts where pre-existing conditions were also not ideal, so support is even more limited than what was there before or totally absent. Think about, again, the context of Gaza, the context of Sudan, or the context of Ukraine. Skill counseling is a big challenge, and I know my colleague from WHO highlighted the guidance that was issued a few years back on the need to invest more on creating capacity around skill counseling. So all of this, again, opens the gates to breast milk marketing and breast milk donations. And this is unfortunately the real challenge that we still have to find a way to address. Next. But we know what else protect breastfeeding in our newborn care. So I'm not going to repeat those recommendations, but this again remains solid and remains central even more so during a crisis. Next. And I want to reiterate the issue of marketing. Marketing is deliberate. It's not a mistake of the company. It's not a chance of the company. It's something that they do intentionally and something that they plan and invest on. So there are several ways the industry is marketing also in an emergency context through personalized approaches, algorithmic amplifications, using AI, as unfortunately AI is also being used to increase influencers and to increase messaging that also echoes in our emergency context, and then to reach out health systems. Hence, it's a growing and blooming industry. And the code, as was mentioned earlier, is meant to regulate such an environment, not just the product, but the environment as a whole. Next. And why formula donation? Infant formula donation is a challenge for an emergency, is a challenge during emergencies. We have extensive evidence, documented evidence that highlights how unregulated donations disrupt breastfeeding practices and transfer the risks to situation or to women, to their children that are already have very big challenges to secure access to safe water, utensil, and fuel. So when donations bypass support, what we are seeing is that, again, disrupted practices. We have unsafe dilution. It's being used with contaminated water. It's never sustaining the needed supplies, the needed time for the child. And again, we have measured and documented water-related infection risks. So and again, we are not saying we may not need formula in emergency, but if and when formula is really needed, then we need to make sure that we have the right products, the right quantity, that we have the safe water, fuel, and clean preparation. It's recommended to use cup feeding, not bottles. And it's recommended that there is a targeted supply that is accompanied with counseling and follow-up. So we have protocols, we have standards for those infants needing infant formula, but only for those infants, right? So again, donations of formula, and we have documented that disrupt breastfeeding and shift the risk to the infant and to the caregiver, putting the child at risk also of his life. Next. Looking at Gaza, I know this is an example that we wanted to highlight. I think we are all familiar with the tragedy of Gaza. We have documented malnutrition. We have documented the need for nutrition support, but we have had challenges in documenting the needs for breastfeeding support, the need to protect breastfeeding. So what has been the evidence? The evidence that we have collected from Gaza, the evidence that colleagues and agencies in Gaza were able to document is that the importance, reiterated the importance of feeding the mothers, going back to the maternal nutrition component, that is also generally absent from our emergency response. So having a very strong maternal nutrition component in a context like Gaza, deploying or supporting skilled support, very preferable than formula in a condition where water and sanitation is extremely poor. And then keep the alternatives very targeted. Again, we have protocols, we have standards for relactation, even in contexts like Gaza, there are standards and protocols for wet nursing, and certainly there are standards and protocols for formula. But this is also what Gaza once again reminded us, that we need to deploy all the possible breastfeeding protection and support measures, as well as be ready to provide alternative supports when breastfeeding is not practiced, even prior the emergency itself. Next. So what has been, based on our experience across contexts, based on our experience across Gaza in particular, what are the actions that we recommend? And I think it's an emphasis of what has been mentioned already. Do not separate mother and babies. This has been a key challenge in every context, in every conflict context. Protect feeding, the frequency, the expression, help women express, help women preserve their breast milk for times when they may not be able to breastfeed. Keep investing in maternal nutrition. It's crucial, it's critical. Ensure assess before providing supply on any formula when formula remain the last resort. And treatment of malnourished children, either severe or moderate, should follow protocols. Don't use formula as form of treatment. And this was also seen when formula is donated in a disproportionate way. People use it for treatment, and that's not a treatment for sure. Next. And I'm bringing it to this stage to say that we do have global, as I said, global standards, global recommendations, and these were also endorsed by the World Health Assembly in 2010. This is the Infant and Young Child Feeding and Emergency Operational Guidance. So this provides 6 critical steps that will help us promote, protect, promote, and support infant and young child feeding in an emergency. So I really encourage all of you to have a copy, to read it. It's available in around 20 languages. But it's really our go-to guide when we want to start preparing and responding to emergencies, and we want to look at the IYCFE component of it. Next. This is some of the ways you can protect and promote breastfeeding in conflict or context. AI can be of support, peer support systems, and cash for nutrition. These are some of the modalities that we can look at. But again, it's just to say that we need to be able to deploy different measures, different interventions to be able to do what we are discussing today, the protection and promotion of breastfeeding. Next. So in conclusion, again, a reiteration of what has been mentioned, and for me, it's really to treat mothers on milk as a critical infrastructure of our newborn care interventions. And it goes without saying, we need to increase, we need to do more for investing in our lactation capacity at the ground level, cross-sectoral trainings that don't limit to health and nutrition. Much of the work is done also by protection and other colleagues. And it has been mentioned, code monitoring, code enforcement. Next. And I think that was the last story. So thanks a lot to everyone, and happy to answer any question.
Thank you so much, Alessandro from FHI 360 for that wonderful presentation about your experience in conflict regions or rather fragile contexts. Ladies and gentlemen, we've heard from 4 exceptional colleagues. They've shared the evidence, they've shared their experiences across conflict regions, and we've heard from them practical solutions to be able to ensure that we are really protecting and promoting breast milk feeding. I would like to encourage all of us to put our questions in the Q&A section at the bottom of your screen. But for now, because of time, I will turn over to Dr. Mariana and ask just one question that seems to be a common thread. We've heard from you that zero separation is the standard. We've heard from you and many others on this panel. However, we've also heard that zero separation is not happening within this fragile context. In your expertise and in your experience, one, what is the most common reason your teens are seeing as one of the reasons for separation? And in context of active wars, active outbreaks of diseases, what can healthcare workers realistically do to ensure that zero separation is the standard? In just 1 or 2 minutes.
Thank you, Emily, for that question. So to address the first one, I think we tend to think that if we don't have a designed facility like the one that I presented to you, then we cannot do zero separation or that we cannot integrate components of it. But as I showed in one of my slides, there are steps, little steps to walk towards zero separation. So if at the moment the standard in your facility is to take the newborn to a cot, dress him up, and place him away from the mom, that can be already addressed and try to keep mom and baby together. Try to put the baby to the breast in the first hour of life. If in your facility there isn't a space in the neonatal ward to accommodate the mom and the baby, and the teams are working separately, can we add a chair so that the mom can stay in the neonatal ward? Can we not think of the mom as a visitor, but more as part of the diet and let her into the neonatal unit every time she wants and every time she needs? There are small steps to take towards, and that's why I wanted to highlight that this is very much the standard that we're working towards in MSF, but it is not a reality in all of our projects and at all levels. So it is taking it step by step. And regarding the question on outbreaks, the outbreak sort of like modifications that need to be done depend on the outbreak. So I'm going to take the most extreme example being Ebola at the moment, for example, the outbreak of Ebola in the DRC Congo, where the current recommendation is to separate the mom and the baby, unfortunately. The current recommendation is to stop breastfeeding because of the high risk of mortality for this infant if the infant has not been infected. So that would be the most extreme context I can imagine for this. But in most contexts, in most contexts, we would be able to adapt. Thank you.
Thank you so much, Dr. Mariana. Ladies and gentlemen, we've heard from the experts. There are practical steps that we can take to ensure that we are supporting mother-baby dyads to have successful breastfeeding, even while in fragile contexts. And I'll share with us a few action points that we need to address across for all of us within healthcare. We've had, key insights around zero separation being the goal, ensuring that we are keeping mother and baby together, but also ensuring that we are providing coupled care at every level of care. This is really important, and we've had different speakers share about this. And importantly, for implementers, policy and system actors, it's important for us to look at key action points around ensuring that we have policies, ensuring that we have clinical practice guidelines, ensuring that we are generating data for decision making, but also that we have the right financing and also human resources to support breastfeeding at every level, including fragile contexts. Next slide. We have come to the end of this really exciting webinar, and I'm hoping that we have come away with these action points, and we are going to take back home some of these learnings to ensure that we are supporting mother-baby dyads everywhere, particularly in low-middle income countries. Before I close, I would like to share that this webinar has been recorded and you can review the film after this session. And also, please do not forget to share with colleagues. In addition, we do have upcoming webinars. We do have, as was mentioned earlier, the neonatal antimicrobial stewardship webinar on the 8th of September, and another one related to perinatal palliative care on the 20th of October. And remember, both of them will be done in both English as well as French. Next slide. And as always, as we come to the end, we want to send a big thank you to the partners who have been able to put this webinar together, Nest 360 and PATH, with support from Paolo Chiesi Foundation, as well as UNICEF and the London School of Hygiene and Tropical Medicine. We also want to recognize the funders for Nest 360, as well as the French Toolkit. But we also want to recognize the Toolkit expert advisory team, as well as the Toolkit team based out of LSHTM. Thank you so much to Dr. Ameena, Dr. Mariana, Dr. Frank, Alessandro, and all of you for joining us today for this webinar. Have a good one.